Well, good evening, America. It's that time again, Tuesday night at 5 o'clock Central Time. 5 o'clock on the Gulf Coast, which means 6 o'clock in the East, 4 o'clock in the mountains, and three on the West Coast. And it is time for Fertility with Fink. I'm Dr. Randy Fink, live tonight from Pensacola, Florida, where I am a fertility gynecologist here at New Life Fertility. In Pensacola, we have offices in Panama City. We have offices in Mobile. We see folks from all over this great country of ours. And so a very happy and special Thanksgiving week to everybody here tonight. Thanks so much for being here. This is my favorite time of the week. It's the time that we get to sit and talk about all those things that are important to us, the things about making families, the things about having babies. And all those things really tonight that we want to give thanks for, and that's thanks for each other. At 5:30 tonight, we do the 5:30 Fuzzies with Fink, and that is where we're going to just sort of shout out to everybody who needs a little extra help tonight, whether that is dealing with this fertility business and all the stress that comes along with it, whether it's relationship issues or job issues or just life issues out there, to know that there's a group of people around together who are willing to stand by you under any circumstances is just a little extra niceness in the world. And that's what we're out to do. How's it going? I hope your weekend was great and that this very special week is coming up for you. I hope that you don't have to do all the cooking yourself, that everybody has someplace to go. And that, well, if you're not cooking, then at least maybe you're doing a little bit of cleaning afterwards. I don't mind the cooking part. I just don't like the cleaning part. And especially after eating a big Thanksgiving meal, I kind of become a couch potato, and which is not to say that I'm not a couch potato before the Thanksgiving meal either, kind of on a baseline couch potato, but it is a favorite time of year for many of us. It's also a time of year that creates stress for a lot of people. And so I hope that you're not overwhelmed with family and with friends and all those things that these holidays bring around, especially as you're dealing with fertility concerns. A lot of times, these holidays can prove challenging. People asking you things like, so when are you going to have a baby? When are you going to get pregnant, for crying out? When are you giving us grandchildren? Or, your sister, she got pregnant right away. I don't know what your problem is. So those things are real. That challenge is real. What do you say in that situation, especially if you're dealing with fertility concerns yourself? And I think maybe a good answer there is to say, well, we're trying. Thanks for your concern. And leave it at that. I think if you can say that, we're trying, thanks for your concern, that pretty much shuts it off right there. And that's what you want to do. You don't need to be rude about it, but you just kind of want to shut it down, because it's not necessarily the sort of thing that you really want to have to keep talking about it if you don't feel like it. And if you do feel like it, by all means, talk about it. But that's your call. And the holidays are supposed to be about joy, about happiness, really about things that make you happy. So don't let the other people make you unhappy by calling to your mind those things that may be causing you stress. So that's my 2 cents worth. Hi to Sheila. Hey, Simona, good evening. Thank you for being here. Dr. Hassa, I believe that says. Lindsay Davis, thank you for being here this evening. Happy Tuesday. We've got some different feeds here. We've got Facebook and Instagram and YouTube right here. We've got New Life's Instagram over here. Did I say Facebook, LinkedIn, and YouTube? Yeah, and we've got my Instagram right here. That's Randy Fink MD. So let's see who we have over here on this side. Hello, Simona. So Simona, I have to say, is an extraordinary nurse practitioner and nurse midwife who runs our Panama City office. Simona is not only an incredible human being, Simona is a wonderful practitioner. She's a great person to talk to work through these issues, and she is also here for you. She's always there. My friend Timmy says gobble gobble and gobble right back at you, and a little meow along with that too. Hi Jazzy Poo. Angela, good evening, my friend. Hi Marlena. Hi Zenny in Miami. Thank you for being here. Baby love, good evening to you. I think that says Cyrus. Howdy Cyrus. SM Frederick. Hi Rosa. Victoria Lynn. Howdy. Lexi is here with us from the Carolinas. We've got Mons 53, Marie, the Kelsers, and Marlena. Marlena, you were the first to join this evening, so thank you for being here tonight. Got a couple of questions starting to float here. And by the way, if you have a question, by all means, throw it my way. That's what we're here for, to try to answer all these questions and give you some stuff to think about here tonight. Rosa says, thanks for being here. It is my pleasure. And her question is, do I need to take prenatals after delivery? And the answer is yes. I do recommend that you are on a prenatal vitamin and omega-3 or fish oil, especially while you are breastfeeding. So there is some very good evidence that says that the fish oil or omega-3, also called DHA or EPA, omega-3 fish oil, is associated with improved thought processing scores as well as visual acuity. So better brain function and better vision in offspring who are breastfed by moms using omega-3. Furthermore, it's a pretty good anti-inflammatory and antioxidant. The other thing about that, so if you're not breastfeeding, I'm not sure that you need to take the omega-3, but I usually recommend that you stay on the prenatal for at least 6 months after having the baby, because you are nutrient deprived, after delivery. The body is going through a lot of adjusting there. And so being able to kind of refill your tank with the right kind of micronutrients really does help you to recover more quickly. So prenatal vitamin, yes. And if you're breastfeeding, please add omega-3. One little aside about the omega-3, and that is that, it literally is the oil that comes from a fish. And usually, in many cases, it comes from a sardine. They take a little sardine and they wring it out. So if you get omega-3, get the one that says odorless or burpless, because if you burp up that sardine oil, you will never want to be in the same room as a capsule of fish oil again, perhaps even in the same zip code, because it's pretty horrific. It's pretty awful, that taste. So the odorless or burpless ones either have they have maybe a little lemon oil or something in them, so that if you do burp it up, it's not unpleasant, or they are formulated, instead of dissolving in your stomach so that you will burp them up, that they pass through to the small intestine, and that's where they open up, and you're able to retrieve the nutrient from it. So Victoria Lynn says, how do you think? Transfer was 11:21, and I was told my embryos took extra to start expanding 3 hours before being thawed. Is this bad? So I think what you're saying is that when they took your embryos out to thaw them, that they just took a little extra time to expand. No, I wouldn't say that that's necessarily an indicator of anything. It's a biological specimen like anything else. So basically what happens is when they go to freeze an embryo, which is a process that's called vitrification, what they're doing is that they are quite literally taking every droplet of water out of the cell. Because if there's a drop of water in the cell, that when they freeze the embryo, that drop of water will freeze and crystallize and can damage the substances in the cell. Now, fortunately, we have come a very long way with vitrification. We really know how to do that, and we can do that very, very effectively. So much so that when you're freezing an embryo and you thaw an embryo, that embryo thaw survival rate is probably pretty. Most labs will report 92, 93%, but in reality, it's probably close to 99%. We've become so good at vitrifying embryos. But you can imagine if you're taking the water out of the embryo that it may start to collapse, so that then once you start to thaw it, it starts to re-expand. And that's kind of what they're talking about with that re-expansion. The fact that it takes a little extra time to re-expand, to me, doesn't say necessarily that there's a problem there. So no, Victoria, I don't think that's something that you have to fear. So fingers crossed on that one. Transfer was 11/21, so you are now 4 days past transfer. Fingers crossed for sure, Victoria Lynn. Let's see what else we got here. Happy Tuesday to you, Miami, Florida. Zenny, I appreciate you being here as always. Marlena says, hi, Dr. Fink. Is there was a medication that you talked about last week that you use for patients with a positive ANA. Do you use this only for IVF patients, or could you use those doing medicated cycles? Use it too. So when you say the medication that I was talking about there is called Plaquenil, and Plaquenil, the generic is called hydroxychloroquine, and it has the potential to really be able to take a positive ANA and potentially even make it negative again, which is pretty impressive. That I can do that. So no, I don't reserve that just for folks who are doing IVF or who are doing, well, really the more important part there is at the time of an embryo transfer, because what we're trying to do really is to suppress the immune system at the time of embryo transfer, so that the body isn't creating an immune response against your own pregnancy. But for folks who are doing things like an IUI or ovulation induction, that particular medication is okay to be on. And so, yes, I do use it in that scenario as well. There are some medications as part of an immune protocol that I do not use in folks who are doing IUI or ovulation induction, just because it's not practical to do it. Things that are really better studied in embryo transfer and things like for IVF, or things that just cost-wise, we don't want to put you on unless we have something that has really a very high probability of a pregnancy. But yes, absolutely. Plaquenil is okay to use in ovulation induction cycles, and it would be something that I would recommend if you have a positive ANA. Another thing that is actually really good kind of anti-inflammatory medication is called low-dose naltrexone, and many of you may have taken that before for one reason or another. Low-dose naltrexone, and the naltrexone medication in its standard dose is a 50 milligram capsule. I think it's a capsule, maybe it's a pill, probably a capsule. But naltrexone is designed to block the effect of opiates. So let's say that you are a heroin abuser, and we can put you on this full dose naltrexone, and you can shoot up, and it doesn't give you the euphoria that you would expect. So it blocks it. It's a disincentive to using the medication. Low dose naltrexone is 4.5 milligrams. So really a tiny fraction of the dose. And what it does is that it partially blocks those opioid receptors in the brain and results in a reflex increase in your endorphins. And by increasing the endorphins, you can therefore stimulate the good parts of your immune system and suppress the bad parts of your immune system. So that's really a good thing. It's very safe to take on the long term. And that's something I tend to use also. I feel very comfortable with using it frequently, whether you're doing IVF or ovulation induction. So yeah, absolutely. Let's see. We said hi to Angela there, and Angela had a question. Is the Receptiva test the same as an ERA? I know you said that Emma and Alice are not that accurate. So no, it's not the same test. The ERA is an endometrial receptivity assay. And what that was predicated upon was this idea that we each have a very specific window during which time we can implant an embryo. And the thinking was that 75% of us implant at the usual time, and that 25% of us don't. And we wouldn't know whether we're in the 75th percentile or the 25th percentile unless we tested for it. It's an expensive test, but the data on it shows us that it's really not so useful, that the outcomes looking at many, really tens of thousands of cycles, having done the ERA and having changed something based on that does not affect the pregnancy rate or the live birth rate. So we've really gotten away from doing that ERA as a part of the evaluation for implantation failure. So ERA is something different. Receptiva is designed to test from the endometrium for a marker called BCL6, and that is, technically speaking, it's a test for endometriosis. So if you're positive for BCL6, we think that BCL6 may function as a result of endometriosis as something that may block your progesterone levels. It may block progesterone at the level of the endometrium, and progesterone is the hormone that we need in order for a pregnancy to continue. If your BCL6 is positive, it means that there's a very significant effect on your ability to implant an embryo, unless we treat it. And by treating it, we suppress that endometriosis for 60 days, either with Lupron or with a medicine called Orilissa or one called Myfembree. And suppressing that endometriosis returns your ability to implant that embryo to exactly where it should be, really completely back to normal. So I do think a Receptiva, or a test for endometriosis, is really an important part of the evaluation for recurrent implantation failure, potentially even for recurrent pregnancy loss. Whereas the ERA, I don't think really has a role so much anymore. But that's a very good question. Receptiva is not the same as an endometrial receptivity assay, even though that receptive word is part of the name. So there you go. Jay Bizzle, good evening, sir. And let's see here. What do we got? Plant Honeys. Hey, how are you? A. Garrettson. Bryn, good evening to you. Mrs. Villarreal, thank you for being here, as always. Abyss Barnett. Looks like Zamina, how are you? Zamina has a question here. Is 0.12 too low for a retrieval? And I presume you're talking about like an AMH level. So an AMH, so what is the AMH, the anti-Mullerian hormone? Well, let's talk about what that really means, first of all. The AMH, and I do feel like every woman should know what her every woman of reproductive age should know what her AMH is, because it is an important marker for us to be able to understand where your ovaries are in time. All right. So what is it? We can't actually count the number of eggs in your ovaries because they are microscopic. And so we look, and there's still, probably millions or hundreds and hundreds of thousands of them. So we can't see them. What can we do instead? Every little egg is surrounded by some cells, and these cells secrete a hormone, and that hormone is called anti-Mullerian hormone, or AMH. So the more of these cells you have, the more AMH you make, and the more AMH you make, the higher is considered to be your ovarian reserve. So we measure that amount of hormone in your blood, and we can plot it out on a graph to kind of see where you are relative to other people your age. And that's the significance of an AMH. It tests for what we know of as ovarian reserve. Now, an AMH of 0.12 is considered a diminished ovarian reserve. That is a low number. The AMH is not a measure of your fertility. It is not a measure of whether or not you can get pregnant, okay? And that's a very important distinction. What it does tell us is that it is suggestive of how your ovaries are going to respond to stimulation medication. That's really what it's for. And an AMH of 0.12 tells me that you're going to probably need high dose of medication in order to, if you believe that. There are some people that believe a high dose doesn't make a difference, and so they will use a low dose under any circumstance. But traditionally, it means that you'll need more medicine in order to stimulate your ovaries, and that our expected yield from that medicine is going to be lower than it would be for someone with a higher AMH. So is it too low for a retrieval? And the answer is no, because all it takes is one egg to get the job done, right? One egg, one sperm, one embryo, one baby. However, what I would caution you about is that, well, I want you to be realistic to expect with your stimulation. My guess is that with that lower number, you're probably not going to get 10 eggs. You're going to be limited in the number of eggs that you retrieve. And so it may realistically take you more than one cycle in order to get the number of eggs that you need to make the number of embryos that you're comfortable with to feel confident that you're going to get a baby from that process. So no, it's not too low, but it does say, yep, it's an uphill climb. But the answer is always, there is hope. Hi, pretty girl Key, it looks like. Shadia, hello. Nice to see you this evening. Amber has joined us. I want to send a special shout out to Amber this evening with a very special thanks for the crumble cookies that came our way today. It made everyone very happy, and I think you are trying to fatten us all up for the holidays. Isn't that right? But what a sweet and very thoughtful gift, Amber. Thank you very, very much. And fingers crossed here, young lady. Hello to SB Charles, my friend. Good to see you around. And Sheila, howdy. Marie says, at what follicle size should I trigger with HCG? I'm on Follistim, Menopur, Lupron, and Omnitrope. At what size are eggs mature and ready to get retrieved? So, there's a different answer there depending upon what your age is. So usually we think of 17 millimeters. If you're in your 40s, sometimes we'll look at that and say, well, you know what, 16, even 15, 16 may be mature. So mature size tends to be a little bit lower if you're a little bit more mature. That's if you're a little bit more mature. I don't know, that sounds kind of funny. But if you're in your 40s, then we typically use a little bit lower number. But 16, 17 is kind of what we're talking about for maturity for IVF. If you're talking about things, and it looks like you're doing IVF there in a stimulation, but if for things like an IUI, if you're doing ovulation induction, typically we think of about 18 millimeters as the size that I would think about triggering you. That's when I say that single follicle is likely to be mature. Another special shout out to Eileen Bailey. Thank you so much for being here along with your pregnant belly. We cannot wait to meet your baby there, Eileen, and it's great to see you. Happy Thanksgiving to you guys. Thanks so much for being here this evening. We've got Morgan has joined us, as has Samantha, and as has Kaylee. Thank you so much for being here tonight. Pretty Girl says, do you recommend acupuncture before and after a frozen embryo transfer? So, the first thing I would tell you is that there is no harm to doing acupuncture. The evidence is conflicting. because there are people that you can ask who will swear by their acupuncture. There are even some people I know who have studied it and found that there are improved outcomes doing pre and post transfer acupuncture. However, in very large prospective studies where they are choosing an intervention over a non-intervention, acupuncture hasn't shown that it makes a huge difference. So the American Society for Reproductive Medicine basically says, it doesn't harm anything. And it may help because it may help to relax you. It may help with some blood flow issues, and that's a good thing. You may know that where I used to work, they offered, on-site pre and post-transfer acupuncture. And the acupuncturist there was wonderful and really very solid, very qualified. But the truth is, there is not overwhelming evidence that doing pre and post transfer acupuncture affects outcomes when you look at the large prospective studies. So if you weren't able to do it, I don't think that you should feel badly about that, because I don't think you're harming anything. Certainly, if you have the ability to do it and it's affordable, then I think, sure, it's a fine intervention to do, but it is not a deal breaker. And I do know that there are, I've met plenty of people who just felt awful that they weren't able to get into town early enough, or they weren't able to get their acupuncture done. Maybe they were having a transfer over the weekend, or something was going to happen that stood in the way of them being able to get the acupuncture, and they just felt like that they were signing off on the whole transfer cycle, that it wasn't going to work, and it is not that significant. So I would say if you're able to do it, it's not going to harm anything. Might it help? It just might, but the evidence is not super strong. Hi, Easy Breezy. Do you prefer ICSI or conventional IVF in older women getting 7 to 8 eggs? In general, I prefer ICSI under most circumstances. So the difference there, conventional IVF was where we do your stimulation, we retrieve your eggs. These eggs all go in a dish. Basically, we take the sperm and we dump the sperm into the dish, and then we just leave it alone and look at it the next day. So fertilization rates are higher when you use ICSI. ICSI, ICSI, stands for intracytoplasmic sperm injection. And what they're doing there is that they are taking one individual sperm and they are placing it inside each egg. Fertilization rates are higher. Most practices in the United States do ICSI as a standard of care. The only circumstance where I feel that I feel stronger about conventional IVF, and this is really the only circumstance, is when someone has a history that they've done a cycle and that the egg quality was just so poor that when they tried to fertilize those eggs, the eggs just kind of came apart. And if that happened to you, then I would say, you know what, conventional IVF is probably a really good option. The reason that I wouldn't say it's the best choice for everyone is, well, number one, with ICSI, as I said, the fertilization rate is going to be higher. You're going to get more eggs that do fertilize. But secondly, if the eggs do not fertilize, then typically what they do is called rescue ICSI, and they try to take the sperm and they put it into the egg that's there, and the outcomes associated with that are not nearly as good. So I do prefer ICSI over conventional IVF. And most labs, that's really what they're doing now. Hi, Midgie. Nice to see you tonight. Good to see you and Mrs. V. Happy holidays to you. And to Mr. Max, thank you for being here, sir, who has traveled all the way to Florida from Denver, Colorado. And Angela has a question here. But before we get to that, guess what time it is? It is 5:30, and it's time to do this thing. The 5:30 Fuzzies with Fink. This is really an important time. At the end of my show, you may have heard me say that there is not enough kindness in the world, and that you should, as best you can, try to take every step forward with kindness. The folks who typically come and watch my show are usually pretty good people. In fact, I would say that all of you folks are probably way better than average kind of people. And I know in my heart that if any one of you was hurting, or if any one of you was in need of some extra support, certainly I would be here. And I believe every single other one of you would be here for all of the other people who watch this broadcast. And so at this moment at 5:30, we take just a second to say, I'm sending out good vibes to everyone, not just about the world of fertility and all of the grief and angst that this causes, but also the other important things in life, things about relationships with your family, relationships with boyfriends, girlfriends, spouses, things about work that are challenging, things about your car breaking down, things about your neighbors that you're disputing with, all those things that cause us stress in our lives. We are here for each other, and we stand together tonight as a community, as one, to say life is gonna be okay, and that we are here for each other, and that tomorrow is a new day. So good vibes to everybody. And that, my friends, is the 5:30 Fuzzies with Fink. If we all think about it and send that good energy out right now, then maybe we can break the internet with good energy. Let each of us be a recipient of that energy from each other. Thank you so much for sharing that. Okay. All right. Angela, you said I used letrozole 7.5 milligrams this cycle with Menopur and Gonal-F, and now 5 days of stim, my estrogen went above a 34. Usually my estrogen is 400 to 500 by 5 days of stim. Letrozole has oversuppressed me, and I'm having hot flashes. Okay, well, so here's what you have to know. It's not necessarily that it oversuppressed you, but letrozole does, in fact, block your estrogen. So if you're using letrozole, your estradiol level in your blood is meaningless. It is artificially lowered, and so you cannot assume that the number that you get from your blood means anything. It is not predictive of the number of eggs that you will retrieve. You're using Menopur and Gonal-F, so you're using a lot of extra. You're using FSH to stimulate your ovaries. Presumably your ovaries are stimulating there, but you wouldn't know it from being able to look at your estradiol level. So normally what I would expect is, about anywhere from 150 to 250 is the level I would expect for a single egg in your ovary. So if you are at 400 to 500, by 5 days of stim, I would start to think, 150 to 250 for a mature egg. So if somebody came in, they had an estradiol of 500 at the time of retrieval, I would think, we're probably going to get anywhere from 3 to 5 eggs. Just, ballparking it. But on letrozole, forget about it. Not a useful measurement. So don't even look at that estradiol. It's a fake number. Oh boy, yeah. And that's a kind of a battle of mine that my feeling is, it is a fake number, and it's going to be a fake number. So why even test it? It's not realistic. It is not reflective of what is actually happening in your body, except to say that the letrozole did something. It blocked your estrogen. And when you block your estrogen, your body makes more of its own FSH to try to increase the stimulation of the ovaries so that you can make more estrogen. So yeah, it did what it was supposed to do, but don't think that the estradiol is helpful for you there in any way. Okay. Letrozole can It certainly causes you some hot flashes. Clomid, I think, is much worse. Clomid shuts off estrogen, not only, well, kind of really all over the body, but at the level of the ovary, the pituitary, and every place else. Whereas letrozole is taking the estrogen that's being created from the way you convert it from testosterone in your fat cells, and it's cutting that off. So it's not shutting down all of your estrogen. The other thing that Clomid does as it shuts down your estrogen is that it can also affect your uterine lining, whereas letrozole does not. Decrease the amount of estrogen you have going to the uterine lining, it may be a lot thinner. And so for folks who are using Clomid, I usually recommend we do some add back estradiol to make sure that the lining itself doesn't get too thin. So yeah, there you go. Let's see what else. Progesterone resistance after embryo transfer. I'd love to hear why you think this is. That comes from Easy Breezy. Well, progesterone resistance, I'm not sure. I referred to that before because we think that the BCL6 marker, which is an inflammatory marker associated with endometriosis, probably acts at the level of blocking progesterone and causing some progesterone resistance. Maybe it blocks the receptors. I don't know that we know really very well how exactly on a cellular or on a receptor level that really works, but that's kind of what I think is happening there, and that's what's postulated is how the BCL6 marker, or really how endometriosis may interfere with implantation by causing progesterone resistance. Yeah. Okay. Howdy to Kristen. It looks like, Kirsten, I'm sorry. Kirsten I think that says, what happens if we go slightly out of the recommended area for POI? Slightly out of the recommended area for POI. Well, I'm not really sure I know what you mean by that. So maybe you can clarify and I'll try to answer. Pretty Girl says, what vitamins or supplements do you recommend to take to prepare for an FET? Okay, there are 6 supplements that are part of the evidence-based protocol for embryo transfer. So number 1, prenatal vitamin. Duh, that makes sense. Take your prenatal. Number 2 is omega-3. Okay, duh. Those are the only 2 vitamins that you need to stay on once you do get pregnant. That's your prenatal and the omega-3. But the other things, vitamin D, vitamin E, CoQ10, and L-arginine. Those are the 6: prenatal, omega-3, vitamin D, vitamin E, L-arginine, and CoQ10. Those are the 6, part of the evidence-based protocol for embryo transfer. Now, there is one potential other. If you know that you have a history of endometriosis, I recommend also 1,000 milligrams of vitamin C. 1,000 milligrams of vitamin C is recommended as part of the evidence-based protocol with a history of endometriosis. Okay. I have a frozen day 3.37 and a 3.8. Should I transfer them both? Well, so really the question is, so what you're saying there, so a day 3 embryo, the problem with a day 3 embryo is that we just don't know what's going to happen with that embryo, right? We don't know if it's going to be strong enough to make a blast. We don't know if it would otherwise survive. So that's why many clinics don't do day 3. They want to create embryos that have a higher probability of being able to get you a pregnancy so that you have to do fewer embryo transfers that ultimately you have to pay for. However, the thinking with a day 3 is that, well, maybe it'll do better in you than it does in the lab. There's not a lot of great evidence with that, but that's sort of the thinking there. I don't have a I don't believe that the embryo grading means a whole lot anyway, but especially in a day 3 embryo. However, what you're talking about is a grade 3 embryo, which means it's a good rated embryo. So good, fair, or poor. It's good, so it doesn't get any better than that. Um, Typically, a day 3 embryo should be about 6 cells. So what that says is that one of your embryos has 7 cells and the other one has 8 cells. And you may say, oh, that's even better. But actually what that probably means is that these embryos may have grown a little faster than anticipated. And if they're growing a little faster than anticipated, then, that may suggest they might or might not be normal. So, it's a cell or two. Does that really matter with the day 3 embryo? The truth is there's just not enough data to stand behind that and say, to give you a definitive answer there. So really what I would fall back on, pretty girl, is how old are you? Because the number of embryos you transfer is really kind of directly related to age. So if you were 24 years old, I'd say no, I still really recommend, especially if it's a first transfer, that you transfer 1 embryo. We don't want you to have twins. It doesn't, putting in more than 1 embryo does not improve the live birth rate. It just increases the risk of pregnancy loss. So now, if you've had unsuccessful transfers before, then potentially putting in more than 1 embryo may make some sense, and doing it with the day 3 is certainly less risky. But I would tell you that a normal embryo is going to grow whether you put it in on day 3 or day 2 or day 5. Normal is normal, and it's going to grow. So I think ultimately it depends on the answer would really fall back on age, and I would go by the ASRM guidelines on that, unless you've had a previous unsuccessful transfer, in which case I would say it's okay to transfer those 2 embryos. Hi, Mona Queen and Sonia. Jajador, I think that says. Let's see what else. Hi, Gwen in Orlando. Nice to see you this evening. Simona says, I think she means the PIO injection. Yes. Here's Kirsten. Progesterone shots in the bottom. They circle. Oh, okay. All right. If you go outside the area in the PIO, or progesterone in oil injection. So they circled the areas to administer, but the circles have worn off. And I'm 6 weeks along right now. I'm scared of doing it in the wrong spot. Okay. I get it. Now I understand. All right. So, when we circle the area on your butt that you're supposed to be giving the PIO shot, what we're circling there is because that's really the center of the body of the gluteal muscle. The gluteal muscle, and the reason that you give this shot in the butt is because it's a great big thick muscle that has a good blood supply to it, and it has the ability to absorb that amount of progesterone in oil. So it just depends on how far outside that region you go, because you can feel back there and you can say, okay, well, right there is a bone and over here is my hip. And so really kind of one way to do it is just to kind of push with your finger and sort of feel where that gluteal muscle is in the hip. And it's usually just kind of depending on you, typically about 6 to 8. Well, let's see, and I'm thinking centimeters, but let's call it about maybe, oh gosh, we'll call it, we'll use 6 to 8 inches, really sort of diagonal from the tip of your hip bone. And if you push with your finger like that on where that muscle is, you will feel probably where you had your shots before. And that's a good way to kind of get it pretty close. Now, if you're doing it yourself, if you're doing your own PIO injections, it can be a challenge, because you kind of have to be able to get back there and see where it is. What I really wish I could do is to stand up in this space and show you my butt. However, I'm not going to do that. What I would say is that, kind of if you're right handed, it's easier to get around here to your right side in order to get there. It's sometimes a lot harder to get it over on your non-dominant side, but you should be able to feel that spot of the gluteal muscle where you've had the shots before, and then you don't actually need the circle that we've drawn. Now, what could you do if you're just really worried, and that's okay. If you have a friend who's a nurse, you can do that. Have them outline it for you. You could go to the fire station and ask the paramedic, hey, can you show me where it is that I'm supposed to do my intramuscular injection, and they will show you. You can ask a friend. I think I just said ask a friend who's a nurse. Go back to your clinic. Your clinic will be able to show you as well. But really, any friend who's a nurse or possibly even a medical assistant, if you have friends who are in the medical field, they ought to be able to show you where it is. But how do you keep hitting the right spot? You can feel you're probably still a little bit sore or maybe a little bit lumpy from where you got those shots before. And that's how you know, without having to follow the little circle. Now I get it. So thank you, Kirsten, for asking that question. And Simona, thank you for reading between the lines there. Hi, Desi Banks. Angela says, what are the reasons for having fluid in the cavity in an ultrasound? Could it be mistaken for it being adhesions or scar tissue? Well, most of the time, if there is fluid in the cavity, it kind of depends on when really you're looking. All right. So if you look right around the time of your period, you may very well have some fluid on the inside because it's blood that just hasn't come out yet, or it's some tissue that's sloughed off that has yet to kind of be able to clear itself from the cavity. If you're doing an embryo transfer cycle and you get closer to the time of transfer and there's some fluid there. In some cases it's blood again, but because of some little hormonal fluctuations. But in other cases, it can be, it's common that we see it in folks who kind of have a little raw endometrium, that the lining itself is just kind of rough from having to grow. Maybe if you've ever fallen and skinned your knee and it kind of gets a little sticky and a little wet kind of looking, or you take the Band-Aid off and it's kind of got this icky stuff on it. Think about that as kind of being the same thing on the inside, that it's just a reflection of the raw tissue. If there is a lot of it, then usually what we do is we cancel the cycle because we don't want that to be there when we place an embryo inside. If there's just a tiny little bit, sometimes we can aspirate that. We can just kind of suck it out at the time of egg retrieval so that then it's gone. If you're doing some intrauterine washes, sometimes we're putting fluid in there. So it's not a problem necessarily that there is some fluid there, but we just don't want that raw tissue and that fluid to be there because it's an inflammatory marker. It's a marker of the inflammation in that lining, and that we just don't want to be there at the time of embryo transfer. But could it be mistaken for adhesions or scar tissue? Typically, what scar tissue would look like is more often a thickening of the uterine lining. So let's say you get your period, you've sloughed off your lining, and that lining should be at its thinnest at the beginning of your cycle. Well, what if we go and do that baseline ultrasound, but find that, oh my goodness, look at there, look at there, that lining is really thick. It should be 4 or 5 millimeters. Well, what if it's, 9, 10 millimeters at the beginning of your cycle? That makes me think, I wonder if there's something else in there, like a polyp or a fibroid or a little band of muscle or some scar tissue. So in that scenario, it's very easy to say, well, let's either do a little hysteroscopy or a saline sonogram, and let's make sure that that lining is normal. That's kind of how I would approach that. Shada, it's good to see you, my friend. Haven't seen you around for a while, and I hope that you guys are doing well. I got a question from Jen here over on the Facebook side. Good evening, Jen, and happy Thanksgiving, impending Thanksgiving to you. What is the percentage of a natural conception with an AMH level of 0.22? So, we talked about it a few minutes ago that the AMH does not represent your ability to get pregnant. What it is not a reflection of your fertility. What it is a reflection of is how you will respond to medication, how easily we can get your ovaries to work if we were to give you medication. And, it is what we call the ovarian reserve, or how many, roughly how many eggs do you have left. Now, it doesn't correlate with a number per se, but rather we plot that out on a graph and see where you are relative to other people your age. So I don't, I think the question of conception, I would still say, 85% of couples are expected to conceive within 1 year of appropriately timed intercourse. And that is across the board with the whole general population, which means everybody really of any age and any AMH. Now, if you're over 35, usually we say, well, if you haven't gotten pregnant after 6 months of trying, we want to see you so that we can kind of get a jump on things, because clock's ticking at that point. So I wouldn't hazard a guess there to say, what are the odds of natural conception, except that it ought to be 85% within a year, irrespective of that number of the AMH. So again, it represents how we expect your ovaries to respond and what we can expect to get from them if we were to use medication. Okay, hope that helps, and happy Thanksgiving to you. Hi, Grace. Grace and Brock, nice to see you this evening. How long after a polyp removal can I schedule a baseline for an embryo transfer? And the answer to that is the very next cycle. So if you've done a polypectomy, to ectomize is to remove a polyp, then, typically that's done in the first portion of your cycle. So by the time you then ovulate, you go on, you have a period, you slough off that lining, you start a new lining, you're good to go, friend. Yep, very next cycle should be okay. Now that can be a little different if it is if you've had a fibroid removed, because a fibroid sometimes may take a little bit more time to heal, but from a polyp, yeah, very next cycle, you're good to go. Desi asked, is it frowned upon for a 38-year-old to transfer 2 embryos? So no, I wouldn't say it's necessarily frowned upon. I would still say, so if you've got, a good, if you have a euploid embryo, which means to say you've tested your embryos, if you grew them to blast and you did the PGT testing, I would say you transfer 1. There are very, very few scenarios where I would tell you that transferring 2 euploid embryos is a good idea. Most of us would not feel comfortable with that, because that goes against really all the guidelines. But if you have, let's say, 2 highly graded blasts at 38, I'd still say, no, you want to transfer 1. If you've had a transfer before and it wasn't successful, then it's not unreasonable to say, yep, you can transfer 2. And certainly, especially that's true if they're day 3 embryos. But blastocysts, I'd say go with 1 is a better choice. And really, why is that? There are people that say, well, we don't mind having twins. We'd be fine with that. We'll just kind of get it all out of the way sooner. I'm not getting any younger. Let me just go ahead and have my kids. And the answer is that multiple gestation pregnancies have many, many higher risks associated with them, specifically preterm labor, preterm delivery, pregnancy loss, lifetime disability, brain injury, What else? Autism risk is increased in multiples. All the risks are increased. And when you look at outcomes from fertility treatments, people say, well, am I at any higher risk for something happening, or there being some adverse outcome with my baby as a result of doing these fertility treatments? And the answer is no, unless it's multiple gestation. So really the risks associated with having babies through fertility treatment is predicated upon having more than one. So if you're having a single embryo creating a single baby, we want you to have one healthy baby at a time. Your risk is no higher than somebody who has not gone through fertility treatment. So we really want you to have one baby, but there are some circumstances where, yeah, it is okay to transfer two. Thoughts on a low-level mosaic embryo? Well, the answer is a mosaic embryo is where some of the cells are thought to be abnormal. Excuse me 1 second here. I just got to plug something in. We have two sets of chromosomes, right? 23 and 23. So 46 chromosomes is what we're made of. So in a mosaic embryo, you have one set of 23 that's normal, but there's something abnormal in the other 23 chromosomes. So that's what a mosaic is. And there's one thing that's called a low-level mosaic. There's one thing that's called a high-level mosaic. Low-level mosaics are said to function just like regular embryos in most cases. In fact, there is some controversy over whether they should be called mosaic or they're just really called normal. A mosaic embryo is not a throwaway. Because in many cases, our bodies do have a DNA repair mechanism. And so we can repair some of that damaged DNA. There is a slightly higher risk of miscarriage associated with a mosaic embryo, but a mosaic embryo in most cases still has a higher rate of giving you a live birth of a normal baby than does an untested blastocyst. So at the top of the list is always going to be that embryo that says it's euploid, which means it's 46XX or 46XY. That's always going to be at the top of the list. Next is the mosaic embryo, and then comes the untested blast in terms of outcomes. So yeah, I think in general, you can feel pretty good about a low-level mosaic. And we do transfer those embryos. And in most of the clinics that I'm not aware of a clinic that will not transfer a low-level mosaic, because in most cases, it is considered to be a normal embryo. Let's see. Great options for making a PIO area. Yes, indeed. Come here. We'll draw it on you. Let me draw a face on your hip and then take pictures of it. But we'll have fun with it for sure. Kauser says my recent IVF cycle with a 3/8 grade day 3 embryo was not successful. Before starting the next cycle, could you please advise what additional tests or evaluations you recommend to understand why this cycle failed and to improve our chances for the next round? So I'm so sorry to hear that transfer was unsuccessful, because every time we do this and it doesn't work, it's a heartbreak, and it's a very hard thing to have to deal with. It's a loss, really, like any other loss in our lives. And I think you can grieve that loss. And I think that's important. In reality, the day 3 embryo, as I said, we just don't know if that embryo would survive anyway. And that was a 3/8. A 3-6 is typically what we consider average, which means it's a good grade embryo. There are 6 cells by day 3. If there are 8 cells by day 3, that means it may have been growing a little faster than anticipated, and it may have a greater probability of not being normal. So my guess, Kauser, is that this was an embryo issue, that this is not an issue with you. And I think that's an important realization, because we're always looking to say, well, gosh, what can we do? Should we change a protocol? Should we, what other tests? Should we use other medications? At the end of the day, we have to have an embryo that will give us a pregnancy in order for that embryo to stick. And that is the far and away most common reason that somebody does IVF, transfers an embryo, and doesn't get a positive pregnancy test. So I'm not sure how many cycles you've had before, or how many transfers you've done before. I certainly would want to make sure that your cavity is normal, either a saline sonogram or a hysteroscopy if you haven't had it within the past year. I would want to look at the hormone levels associated with your cycle and see how it was done, whether that was a programmed or medicated cycle, or whether that was a natural or a modified natural cycle. And just kind of depending on, and really I like to look at immune things to say, well, what are your risks there that your body could be trying to stand in the way? And is there anything we can do in terms of an immune protocol that may help? But what I want to impress upon you is that there is probably a 97% likelihood that the reason that transfer didn't work was because of the embryo itself, not at all because of you. So that said, we are run out of time tonight, friends. So I want to say and close the program here like I do every week by telling you that this fertility business is not the book of your life. This is just a chapter. And what are we doing? We are here to rewrite that chapter. So let's do that together. Every step forward with love, and every step forward with kindness, because as we said, the world is not a kind enough place. Let's send out those good vibes to everybody at every opportunity, because that's how we make the world a better place. Remember, tomorrow is a new day, and it's full of all new adventures and all new hope. Every step forward with hope. Happy Thanksgiving to you, my friends. Thanks so much for being here tonight. I'm Dr. Randy Fink from Pensacola. Good night.